Welcome once more to this YouTube channel. Kindly subscribe to this channel. The topic is pelvic viscera, part 3. I'm going to be talking about the female internal genital organs in the pelvic cavity. Right here is an illustration of the female internal genital organs in the pelvic cavity. You can see the vagina there. Take a close look. You see the vagina, the uterus, the uterine tubes, and the ovaries. The ovaries are also called fallopian tubes. They are all illustrated in this diagram. So the female internal genital organs include the vagina, the uterus, uterine tubes, and ovaries. These organs are seen in the pelvis. I'm going to start right away with a discussion on the vagina. The vagina is illustrated also in this diagram. Look at the lower part of the diagram, you see the vagina. Of course, the other viscera are there as well. The cervix, the uterus, the uterine tubes are all illustrated there. The vagina is a musculomembranous tube. It's 7 to 9 cm long. The vagina extends from the cervix of the uterus to the vestibule. The vestibule is actually the cleft between the labia and minora. The vagina actually has two orifices. You have the vaginal opening, the orifice, and the urethra orifice or opening. You also have the openings of two greater vestibular glands. The superior end of the vagina surrounds the cervix. The vagina has some functions. We love it because it serves as a canal for menstrual fluid. The vagina also forms the inferior part of the birth canal, the pelvic canal that serves as birth canal. Of course, the vagina receives the penis and the ejaculate that comes out during sexual intercourse. The vagina communicates superiorly with the cervical canal. The cervical canal is actually a fusiform canal that extends from the isthmus of the uterus to the external os of the uterus. And the vagina communicates superiorly with the cervical canal and inferiorly with the vestibule. So take a close look at that diagram again. You see the vagina is usually collapsed, is H-shaped in cross-section, so that when you see the anterior and posterior walls, the anterior and posterior walls are in contact, except at the superior aspect where the cervix holds them apart. The vagina lies posterior to the urethra, and the urethra projects into the inferior anterior wall of the vagina and the urinary bladder. And the vagina lies anterior to the rectum and passes between the medial margins of the levator-ani muscles. There is a part of the vagina we call the vagina fornix. This is actually a space, a recess around the cervix that has anterior, posterior, and lateral parts. The posterior vaginal fornix is the deepest part and is closely related to the recto-uterine pouch. There are 4 muscles that compress the vagina and act as sphincters. 4 muscles compress the vagina and act as sphincters. These muscles are the pubovaginalis, the external urethral sphincter, the urethrovaginal sphincter, and the bulbo spongosus. Now, let me mention the relations of the vagina. Anteriorly, you have the fundus of the urinary bladder and the urethra. Laterally, the levator-ani muscles are there. You have the viscera pelvic fascia as well and the ureters. Then posteriorly, you have some structures inferior to superior. Most inferior, you have the anal canal posteriorly now. And then as you go superior, still on the posterior part of the vagina, you have the rectum, and then you have the recto-uterine pouch. The arterial supply of the vagina comes from arteries that supply the superior part of the vagina and the other parts of the vagina, middle and inferior parts of the vagina. Arteries that supply the superior part of the vagina come from the uterine arteries. Arteries that supply the middle and inferior parts of the vagina are branches of the vaginal and internal pudendal arteries. What about the veins that drain the vagina? The vaginal veins form vaginal venous plexuses along the sides of the vagina and within the vaginal mucosa. These veins are continuous with the uterine venous plexus, and they continue as the uterovaginal venous plexus, and these veins drain into the internal iliac veins through the uterine vein. The uterovaginal plexus also communicates with the vesical and rectal venous plexuses. The lymphatic vessels that drain the vagina actually drain various parts of the vagina. So the lymphatic vessels that drain the vagina drain the various parts of the vagina. The superior part of the vagina is drained by lymphatics that go to the internal and external iliac lymph nodes. The middle part of the vagina are drained by lymphatics that drain to the internal iliac lymph nodes. Inferior part of the vagina also are taken care by lymphatic vessels that drain to the sacral and common iliac lymph nodes. Of course, you also have the external orifice of the vagina drained by lymphatics that empty to the superficial inguinal lymph nodes. Now, I have to talk about distension of the vagina. The vagina can be markedly distended, particularly in the region of the posterior part of the fornix. If you have distension of the posterior part of the fornix, it allows palpation of the sacral promontory during a pelvic examination, and it can accommodate the erect penis during extension. The vagina is especially distended by the fetus during parturition, that's childbirth. The distension is in the anterior-posterior direction, particularly when the fetal shoulders are delivered. You also have lateral distension. The lateral distension of the vagina is actually limited by the ischial spines, which project posterior-medially, and the sacrospinous ligaments, which extend from these ischial spines to the lateral margins of the sacrum and coccyx. The birth canal is actually deep anterior-posteriorly and narrow transversely at this point where you have the ischial spines, and this causes the fetal shoulders to rotate in the anterior-posterior plane during childbirth. What about digital examination through the vagina? Because of its relatively thin distensible walls and central location within the pelvis, the cervix, ischial spines, and sacral promontory can be palpated with the digits in the vagina or rectum. This is what is called manual pelvic examination. Pulsations of the uterine arteries may also be felt through the lateral parts of the vaginal fornix. You can also appreciate when there are irregularities like cases of ovarian cysts. You can feel that through the lateral part of the vaginal fornix. I'm not so happy to talk about vaginal fistulae. Because of the close relationship of the vagina to adjacent pelvic organs, you can have obstetrical trauma, that's injury during childbirth. When you have long and difficult labor, the result is weaknesses, necrosis, or tears in the vaginal wall. This injury might even extend beyond the vaginal. So you can have open communications, what we call fistulas, between the vaginal lumen and the lumen of adjacent organs like the bladder, urethra, rectum, or perineum. Urine enters the vagina from both vesico-vaginal and urethro-vaginal fistulas. But the flow is continuous. When it's a case of vesico-vaginal fistula, you have a continuous flow. Then, when it's a case of urethro-vaginal fistula, the flow occurs during micturition. Fecal matter may be discharged from the vagina when there is a recto-vaginal fistula. What about codoscopy and codosynthesis? Codoscopy and codosynthesis. An endoscopic instrument, what we call the codoscope, can be inserted through the posterior part of the vaginal fornix to examine the ovaries or uterine tubes. For example, in the case of suspected tubal pregnancy, that's ectopic pregnancy. There is a less disruption of tissue in laparoscopy compared to codoscopy. So codoscopy has been replaced by laparoscopy, which actually gives a greater flexibility during the procedure and better visualization of pelvic organs. There is also less risk of bacterial contamination of the peritoneal cavity. When there is pelvic abscess in the rectouterine pouch, it can be drained through an incision made in the posterior wall of the vaginal fornix, and the procedure is called codosynthesis. Also, when you have fluid in the peritoneal cavity, like blood, it can be aspirated by codosynthesis. The uterus is an organ that I really need to talk about now. Right here is an illustration of the uterus. You can see a section of there's a coronal section of the pelvic cavity of the uterus, a section of the uterus. You can see the fundus of the uterus. The uterine tube is actually where it's connected to it comes from the uterus there. Then you have the lateral border of the uterus, the body of the uterus, the cervix. They are all illustrated there. There is also another diagram you see showing a section of the reproductive system of the woman, not just the uterus. You also have the vagina, and then the uterine tubes are all illustrated there. So the uterus is seen, the myometrium is shown there, the endometrium is there, and of course the perimetrium is illustrated there, and you can see the cervix. So the uterus is also called the womb. It's a thick-walled, pear-shaped, hollow muscular organ. The embryo and fetus develop in the uterus, so we love the uterus. Its muscular walls adapt to the growth of the fetus and provides the power and the force for its expulsion during childbirth. The non-gravid uterus, that's the uterus that is not pregnant, usually lies in the lesser pelvis, with its body lying on the urinary bladder and its cervix between the urinary bladder and the rectum. You must not forget that the adult uterus is usually anteverted, that it's tipped anterior-posteriorly relative to the axis of the vagina. So the adult uterus is anteverted. The adult uterus is also antiflexed. That is, it is flexed or bent anteriorly relative to the cervix. So the adult uterus is anteverted and it is antiflexed, such that its mass, the uterus, lies over the bladder. The position of the uterus changes with the degree of fullness of the bladder and rectum. The size of the uterus varies, but the uterus is about 7.5 cm long, it's 5 cm wide and 2 cm thick, and it weighs about 90 grams. The uterus is divisible. You can divide it into two main parts: the body and the cervix. The body of the uterus forms the superior two-thirds of the uterus. The body includes the fundus of the uterus, the rounded part that lies superior to the orifices of the uterine tubes. The body of the uterus lies between the layers of the broad ligaments and it's freely mobile. The body of the uterus has two surfaces. There is a vesical surface which is related to the bladder, and there is an intestinal surface. The body of the uterus is demarcated from the cervix by the isthmus of the uterus. The isthmus is a relatively constricted segment. It's about 1 cm long. The cervix of the uterus is cylindrical. It is relatively narrow. It has a relatively narrow inferior third. Cervix of the uterus is cylindrical. It's actually the narrow portion, the inferior third of the uterus, and it is narrow. It's about 2.5 cm long in an adult female that is not pregnant. When you look at the cervix, it has two parts. It has a supravaginal part between the isthmus and the vagina, and there is a vaginal part of the cervix which protrudes into the vagina. The rounded vaginal part of the cervix surrounds the external os of the uterus and is surrounded in turn by a narrow space, what we call the vaginal fornix. The supravaginal part of the cervix is separated from the bladder anteriorly by some loose connective tissue, and the supravaginal part of the cervix is separated from the rectum posteriorly by the recto-uterine pouch. The uterine cavity is slit-like. It's about 6 cm in length from the external os to the walls of the fundus. You also have uterine horns, what we call the canal. They are superior-lateral regions of the uterine cavity where the uterine tubes enter. There is incomplete fusion of the embryonic paramesonephric ducts, and it is these paramesonephric ducts that form the uterus. So when there is incomplete fusion of the embryonic paramesonephric ducts in the formation of the uterus, could have a variety of congenital anomalies. For example, you could have double or biconate uterus. The uterine cavity continues inferiorly as the fusiform shaped cervical canal. The cervical canal extends from a narrowing inside. There is a narrowing inside the isthmus of the uterine body. So the cervical canal extends from there, and that point is the anatomical internal os. The uterine cavity. The uterine cavity continues inferiorly as the fusiform shaped cervical canal. The cervical canal, you really need to know that it extends from a narrowed portion inside the isthmus of the uterine body, and this portion is called the anatomical internal os. So the cervical canal extends from the anatomical internal os through the supravaginal and vaginal part of the cervix, and the cervical canal communicates with the lumen of the vagina through what we call the external os. The uterine cavity, especially the cervical canal and the lumen of the vagina, together make the birth canal through which the fetus passes at the end of gestation in the course of childbirth. The wall of the body of the uterus has 3 coats or layers. You have the perimetrium, which is the serosa or outer serous coat, which consists of peritoneum supported by thin layer of connective tissue. Then you have the myometrium, the middle coat or smooth muscle, which is greatly distended. It's more extensive, though it's much thinner The myometrium is actually greatly extended during pregnancy. So the walls of the body of the uterus, you have the perimetrium, you have the myometrium, then of course you have the endometrium. The myometrium has some branches of the blood vessels and nerves of the uterus located in it. During childbirth, contraction of the myometrium is hormonally stimulated at intervals of decreasing length, and this helps to dilate the cervical os and expel the fetus and placenta, so everyone becomes happy. During the menses, myometrial contraction also produces cramping, which could be painful. Endometrium is the third layer you have in the wall of the body of the uterus. The endometrium is the inner mucous coat. It is firmly adherent to the underlying myometrium. The endometrium is actively involved in the menstrual cycle. It differs in structure with each stage of the menstrual cycle. If conception occurs, the blastocyst becomes implanted in the endometrium. And of course, posterior to the uterus is the rectum. Ligaments of the uterus. Externally, the ligament of the ovary attaches to the uterus, posterior inferior to the uterotubal junction. Very importantly, you have the round ligament of the uterus, what some call the ligamentum teres uteri. The round ligament of the uterus attaches anterior inferiorly to the uterotubal junction. The round ligament of the uterus and the ligament of the ovary are vestiges of the ovarian gubernaculum. They are derivatives from there. And you remember that the ovarian gubernaculum is related to the descent of the ovary from its developmental position on the posterior abdominal wall. Then, most important, you have the broad ligament of the uterus, which is a double layer of peritoneum, the mesentery, that extends from the sides of the uterus to the lateral walls and floor of the pelvis. The broad ligament of the uterus assists in keeping the uterus in position, so it gives support to the uterus. The two layers of the broad ligament are continuous with each other at the free edge that surrounds the uterine tube. Laterally, the peritoneum of the broad ligament is prolonged superiorly over the blood vessels as a suspensory ligament of the ovary. Between the layers of the broad ligament on each side of the uterus, the ligament of the ovary lies posterior superiorly, and the round ligament of the uterus lies anterior inferiorly. The uterine tube lies in the anterior superior free border of the broad ligament, and the uterine tube lies within a small mesentery called the mesocervix. Also, the ovary lies within a small mesentery called mesoovarium, and the mesoovarium is on the posterior aspect of the broad ligament. The broad ligament is actually doing so much, serving as refuge for many structures. You have the largest part of the broad ligament, which is inferior to the mesocervix and mesoovarium, which serves as serving as a mesentery for the uterus itself, and this portion is called the mesometrium. So a portion of the broad ligament called the mesometrium is found inferior to the mesocervix and the mesoovarium, and the mesometrium serves as a mesentery for the uterus. So the uterus is a dense structure, and it's located in the center of the pelvic cavity. You saw that in that diagram. The principal supports, the main supports of the uterus, which holds it in this central position in the pelvic cavity, is courtesy of both passive and active. You have both passive and active or dynamic supports of the uterus. So all these keep the uterus in the center of the pelvic cavity. Dynamic support of the uterus is provided by the pelvic diaphragm. The tone of the pelvic diaphragm when one is seated and standing, the active contraction that occurs during periods of increased intra-abdominal pressure, like when you're sneezing or coughing, is transmitted through the surrounding pelvic organs and the endopelvic fascia in which they are embedded, as the uterus is embedded and the other pelvic organs. Passive support of the uterus is provided by its position, the way in which that's the anteverted and the anteflexed position, the way the uterus rests on the top of the bladder. So that gives passive support of the uterus. When intra-abdominal pressure is increased, the uterus is pressed against the bladder, so it has passive support there. The cervix is the least mobile part of the uterus because of the passive support provided by attached condensations of the endopelvic fascia, that's the ligaments, which may also contain smooth muscle. You have some support, passive support coming from these ligaments, the ligaments which are condensations of the endopelvic fascia. These ligaments are the transverse cervical or cardinal ligaments and the uterosacral ligaments. So both of them give some form of support, passive support to the uterus that keeps it in its position in the pelvic cavity. The transverse cervical or cardinal ligaments extend from the cervix and lateral parts of the fornix of the vagina to the lateral walls of the pelvis. I said ligaments because you have on the right and the left. Then the second one is the uterosacral ligaments. You also have on the right and left. They pass superiorly and slightly posteriorly from the sides of the cervix to the middle of the sacrum. The uterosacral ligaments are palpable during a rectal examination. So the passive and active supports that the uterus enjoys, both supports keep the uterus centered in the pelvic cavity and makes the uterus resist the tendency to fall or be pushed through the vagina. So you cannot have uterine prolapse when the active and passive supports are well done. What about the relations of the uterus? Relations of the uterus. Peritoneum covers the uterus anteriorly and superiorly except for the cervix. The peritoneum is reflected anteriorly from the uterus onto the bladder. The peritoneum is also reflected posteriorly over the posterior part of the fornix of the vagina to the rectum. Anteriorly, the uterine body is separated from the urinary bladder by the vesical uterine pouch. And at this point, you have the peritoneum reflected from the uterus onto the posterior margin of the superior surface of the bladder. Posteriorly, the uterine body and supravaginal part of the cervix are separated from the sigmoid column by a layer of peritoneum and the peritoneal cavity, and from the rectum by the rectouterine pouch. Laterally, what are the relations of the uterus? You have the uterine artery crossing the urethra superiorly near the cervix. So the relations of the uterus, you must not forget anteriorly, anterior-inferiorly sort of, because the uterus is anteverted. You have the vesical uterine pouch and the superior surface of the bladder. Then the supravaginal part of the cervix is related to the bladder and is separated from it by fibrous connective tissue. Posterior relations of the uterus, you have the rectouterine pouch containing loops of small intestine and the anterior surface of the rectum. Then you also have visceral pelvic fascia uniting the rectum and uterus. Here, where you have the rectouterine pouch, what you have visceral pelvic fascia. And this visceral pelvic fascia unites the rectum and the uterus. And we love this fascia because it resists increased intra-abdominal pressure. Laterally, the peritoneal broad ligament flanks the uterine body, and you have facial transverse cervical ligaments on each side of the cervix and vagina. In the transition between the two ligaments, the ureters run anteriorly, slightly superior to the lateral parts of the vaginal fornix. And as the ureters are going, they lie inferior to the uterine arteries. And this is usually about 2 cm lateral to the supravaginal part of the cervix. So arterial supply of the uterus comes from the uterine arteries. You also have collateral supply coming from the ovarian arteries. What about the venous drainage of the uterus? The uterine veins enter the broad ligaments with the uterine arteries and form the uterine venous plexus on each side of the cervix. Veins from the uterine venous plexus drain into the internal iliac veins. The lymphatic vessels from the uterus drain in many directions. They course along the blood vessels that supply the uterus, and they also move along the ligaments attached to the uterus. Most lymphatic vessels from the fundus and superior uterine body pass along the ovarian vessels to the lumbar lymph nodes, what we also call the cava or aortic lymph nodes. So the most lymphatics from the fundus of the uterus and the superior uterine body run along with the ovarian blood vessels to the lumbar lymph nodes or the caval lymph nodes or aortic lymph nodes. They all mean the same. You have some lymphatic vessels from the fundus, particularly the ones near the entrance of the uterine tubes and attachments of the round ligaments. These lymphatic vessels run along the round ligament of the uterus to the superficial inguinal lymph nodes. Lymphatic vessels from most of the uterine body and some from the cervix go within the broad ligaments to the external iliac lymph nodes. Lymphatic vessels from the uterine cervix also go along the uterine blood vessels within the transverse cervical ligaments to the internal iliac lymph nodes. And the lymphatic vessels go along uterosacral, what we call the sacrogenital ligaments, and empty to the sacral lymph nodes. I need to talk about some important procedures and conditions. Very sad is to note is the case of cervical cancer. I will also mention cervical examination and the pap smear. Cervical cancer is very sad to hear about. It's a leading cause of death among women. But now you have a decline in the incidence and number of women dying from cervical cancer, many thanks to cervical examination and procedures like the pap smear. So you have accessibility of the cervix to direct visualization, such that the cell and tissue could be studied by means of pap smears, what we call papinocular smears. And with this, you can detect pre-malignant cervical conditions, and the patient is treated and gets well, and death is prevented. The vagina may be distended with a vaginal speculum to enable inspection of the cervix, that's cervical examination. To prepare a pap smear, a spatula is placed on the external os of the uterus. The spatula is rotated to scrape cellular material from the mucosa of the vaginal cervix. Then what follows, you have insertion of a cytobrush into the cervical canal and this is rotated to gather cellular material from the supravaginal cervical mucosa. So this cellular material is placed on glass slides and is taken for microscopic examination. Examination of the uterus is what I want to talk about now. Examination of the uterus can be done by means of bimanual palpation. The size and disposition of the uterus may be examined by bimanual palpation. 2 fingers of the right hand are passed superiorly in the vagina, while the left hand is pressed posteriorly on the pubic region of the anterior abdominal wall. When you do this, the size and the other characteristics of the uterus can be determined. You can appreciate if the uterus in its normal anteverted position. When softening of the uterine isthmus occurs, that is referred to as Higa sign. The cervix feels as though it's separated from the body. So when there is softening of the uterine isthmus, the Higa sign, the cervix you feel it as if it's separated from the body of the uterus. Softening of the isthmus is an early sign of pregnancy. So once a doctor examines and then observes that, he knows the woman is pregnant. The uterus can be further stabilized through rectovaginal examination. This is used if examination via the vagina alone does not give you clear findings. So you might also want to do rectal examination as well. What are the lifetime changes in the normal anatomy of the uterus? Lifetime changes in the normal anatomy of the uterus. The uterus is one of the most dynamic structures you have in the body. At birth, the uterus is relatively large and it has adult proportions. The body to the cervix, the ratio of the body to the cervix is 2:1. So this is due to prepartum influence of the adult maternal hormones. So the hormones that in the blood of the womb of the mother, of course they play on the anatomy of influence the anatomy of the uterus of the newborn. So it has adult proportions. But several weeks after birth, in the postpartum period, and the dimensions changes, and the dimensions change. The childhood dimensions and proportions are now different. The body and cervix are approximately of equal length. So the body to cervix ratio is 1:1. The cervix has a greater diameter and thickness in the child. Because of the small size of the pelvic cavity during infancy, the uterus is mainly an abdominal organ. The cervix remains relatively large, about 50% of the total uterus, throughout the period of childhood. But when you get a puberty, the uterus, especially the body, grows rapidly in size, and it now gets to the adult proportions. In the post-pubertal, premenopausal, non-pregnant woman, the body of the uterus is pear-shaped. The superior two-thirds of the uterus is thick-walled, and it lies within the pelvic cavity. At this phase of life, the uterus undergoes monthly changes in size, weight, and density in relation to the menstrual cycle. Then, in the course of pregnancy, the 9 months of pregnancy, the uterus expands greatly to accommodate the fetus. The uterus becomes larger and increasingly thin-walled. At the end of pregnancy, the fetus drops. The head becomes engaged in the lesser pelvis. the uterus becomes nearly membranous, with the fundus dropping below its highest level. That's the level at this point. If fundus extends superiorly, that high level at which the fundus extends superiorly to the costal margin during pregnancy, at the 9th month of pregnancy, you find out that the fundus will drop. During childbirth, the level is going to be lower, and you find out that at a month of pregnancy, the uterus occupies most of the abdominopelvic cavity. But after delivery, immediately after delivery, the large uterus becomes thick-walled and it becomes edematous, and its size reduces rapidly. When you look at the multiparous non-gravid uterus, that's a woman that has had several children but is currently not pregnant, has a uterus that is large, that has a large and nodular body, and such uterus extends into the greater pelvis, and it causes a slight protrusion of the inferior abdominal wall, especially in lean women. So when you see such a woman, you know she's a multiparous woman. What happens in menopause? At the ages of 46 to 52 years, the uterus, particularly the body, decreases in size. Then in this postmenopausal stage, the uterus is involuted, and it regresses to a very small size, and it now goes back to the childhood proportions. All these changes that occur in the anatomy of the uterus, it gives a very nice clue, such that when you see the uterus of a woman, what you see varies with the age, the particular age and the reproductive status of that woman. Now, I'm not so happy. I want to talk about this disposition of the uterus and uterine prolapse. When there is increased intra-abdominal pressure, the normal anteverted and anteflexed uterus is pressed against the bladder. The uterus may assume other dispositions. You could have excessive anteflexion. There could be excessive anteflexion with retroversion, and you could also have retroflexion and retroversion. So that instead of the uterus being anteflexed, it could have some other disposition. You could have anteflexion with retroversion, retroflexion and retroversion. So instead of the uterus pressing against the bladder, when there's increased intra-abdominal pressure, the uterus is pushed, so that you have a retroverted uterus. A solid mass is positioned upright over the vagina. So you see it as a solid mass projected. The uterus is projected as a solid mass positioned over the vagina. You now have the vagina inferior to the uterus it now appears as a flexible hollow tube. So a retroverted uterus will not necessarily prolapse, but there is a tendency for it to do so. And when there's a pregnancy occurring involving a retroverted uterus, there is a higher risk of complications. You have high risk of complications. The situation is made worse when there is presence of disrupted perineal body, or when you have relaxed or atrophic pelvic floor ligaments and muscles. So the woman is really in big trouble. Hysterectomy. What about hysterectomy? Because of the frequency of uterine and cervical cancer, hysterectomy may be indicated as excision of the uterus. It's a common procedure. The uterus may be surgically approached and removed through the anterior abdominal wall, or it can be removed through the vagina. Now, innervation of the vagina and uterus. Innervation of the vagina and uterus. What about that? only the inferior 1/5 to 1/4 of the vagina is somatic in terms of innervation. Innervation of the inferior 1/5 to 1/4 of the vagina is from the deep perineal nerve, a branch of the pudendal nerve. And this deep perineal nerve conveys sympathetic and visceral efferent fibers. It does not have parasympathetic fibers. So only this somatically innervated part of the vagina, that's the inferior 1/5 to 1/4, is sensitive to touch and temperature, even though the somatic and visceral efferent fibers have their cell bodies in the same spinal ganglia. Most of the vagina, that's the superior 3/4 to 4/5, is visceral in terms of its innervation. Nerves to this superior part of the vagina and to the uterus are derived from the uterovaginal nerve plexus. The uterovaginal nerve plexus travels with the uterine artery at the junction of the base of the peritoneal broad ligament. This uterovaginal nerve plexus also travels along the superior part of the transverse cervical ligament. The uterovaginal nerve plexus is one of the pelvic plexuses that extends to the pelvic viscera from the inferior hypogastric plexus. Both sympathetic, parasympathetic, as well as visceral efferent fibers pass through the uterovaginal nerve plexus. Sympathetic innervation originates in the sympathetic innervation of the uterus and vagina now. Sympathetic innervation originates in the inferior thoracic spinal cord segments and passes through lumbar splanchnic nerves and the intermesenteric hypogastric pelvic series of plexuses. You also have parasympathetic innervation originating in the S2 to S4 spinal cord segments. The parasympathetic innervation passes through the pelvic splanchnic nerves to the inferior hypogastric and the uterovaginal plexus. The visceral efferent innervations of the superior part, that's the fundus and body of the uterus, and the inferior part, which is the cervical part of the uterus, and the vaginal, actually vary in terms of course and destination. The superior part of the uterus, made up of the fundus and body, actually is intraperitoneal, and the inferior part of the uterus, made up of the cervix, is subperitoneal. So their visceral efferent innervations vary in course and destination. There are visceral efferent fibers which conduct pain impulses from the intraperitoneal uterine fundus and body, and this is actually superior to the pelvic pain line. So these visceral efferent fibers that conduct pain impulses from the intraperitoneal uterine fundus and body follow the sympathetic innervation in a retrograde manner to reach cell bodies in the inferior thoracic and the superior lumbar spinal ganglia. There are efferent fibers. The efferent fibers conduct pain impulses from the subperitoneal uterine cervix and vagina. These structures are inferior to the pelvic pain line. So efferent fibers conduct pain impulses from the subperitoneal uterine cervix and vagina, and these efferent fibers follow the parasympathetic fibers in a retrograde manner through the uterus, vaginal and inferior hypogastric plexuses and pelvic splanchnic nerves, and eventually reach cell bodies in the spinal sensory ganglia of S2 to S4. So note that all visceral efferent fibers from the uterus and vagina that are not concerned with pain, they follow the parasympathetic fibers. That is all the visceral efferent fibers from the uterus and vagina that are not concerned with pain. So that's like the ones conveying unconscious sensations. They follow the parasympathetic fibers in a retrograde manner through the uterovaginal and inferior hypogastric plexuses and pelvic plexus splanchnic nerves to reach the cell bodies in the spinal sensory ganglia of S2 to S4. What about anesthesia for childbirth? There are several options that women have to reduce pain and discomfort during childbirth. General anesthesia is there. It offers advantages for emergency procedures for women who choose it, who prefer it to regional anesthesia. General anesthesia makes the woman unconscious and she's unaware of the labor and delivery. Clinicians must be there to monitor and regulate maternal respiration and both maternal and fetal cardiac function in the course of general anesthesia. Childbirth in such a situation occurs passively under the control of maternal hormones with the assistance of the obstetrician. The mother is free from pain and discomfort, but she's unaware of the joy of the earliest moments of joy on arrival of her baby. Some women prefer regional anesthesia, like the spinal anesthesia, pudendal nerve or caudal epidural anesthesia. They wish to be aware and to participate actively in the course of childbirth. They want to be conscious of their uterine contractions. They will be able to bear down, they'll be able to push, they'll be able to assist the contractions and expel the fetus, but at the same time, they don't wish to experience all the pain of labor. So you could do a spinal block. Here, an anesthetic agent is introduced with a needle into the spinal subarachnoid space at the level of L3 to L4 vertebral level. And you have anesthesia inferior to the waist level. So the anesthesia from the waist level down, the woman feels anesthesia. The perineum, pelvic floor, and birth canal are anesthetized. Then motor and sensory functions of the entire lower limbs, as well as sensation of uterine contractions, are temporarily eliminated. The woman is conscious, but she must depend on electronic monitoring of uterine contractions. If labor is extended or the anesthesia is not adequate, it may be difficult or impossible to re-administer anesthesia. That's in the case of spinal anesthesia. So in this situation, because the anesthetic agent is heavier than cerebrospinal fluid, it remains in the inferior spinal subarachnoid space while the patient is inclined. The anesthetic agent circulates into the cerebral subarachnoid space in the cranial cavity when the patient lies flat following the delivery. A severe headache is a common complaint following spinal anesthesia. What about a pudendal nerve block? A pudendal nerve block is a peripheral nerve block that provides local anesthesia over the S2 to S4 dermatomes. That's majority of the perineum. You also have anesthesia provided over the inferior quarter of the vagina. The pudendal nerve block does not block pain from the superior birth canal, where you have the uterine cervix and superior vagina. So the mother is able to feel uterine contractions. The advantage here is that it can be re-administered, but to do so, it may be disruptive and involve the use of a sharp instrument in close proximity to the infant's head. So you need a very experienced hand to do that. The caudal epidural block is a popular option for participatory childbirth. It is administered in advance of the actual delivery, which is so you give it in advance of the actual delivery. The anesthetic agent is administered with an indwelling catheter in the sacral canal, and it enables administration of more anesthetic agents when you need deeper or more prolonged anesthesia. Within the sacral canal, the anesthetic agent bathes the S2 to S4 spinal nerve roots, including the pain fibers from the uterine cervix and superior part of the vagina, and the efferent fibers from the pudendal nerve. So as a result, the entire birth canal, that's the pelvic floor and majority of the perineum, are anesthetized, but the lower limbs are not affected. So the lower limbs are spared. The pain fibers from the uterine body that is which are superior to the pelvic pain line are sent to the inferior thoracic, superior lumbar levels. So these are the fibers superior to them are not affected by the anesthetic agent. That's when you are doing I'm talking about so in the case of caudal epidural block, that's caudal epidural anesthesia, the fibers the pain fibers from the uterine body that's superior to the pelvic line, pain line, are not affected, and you don't have spinal headache in this after this procedure. I need to talk about the uterine tubes now. The uterine tubes, you have one of the uterine tubes illustrated here. You can see the fimbriae, infundibulum, ampulla, and the isthmus, all illustrated there. The uterine tubes are, of course, part of the viscera you have in the pelvic cavity, part of the female reproductive system. The uterine tubes are also called the fallopian tubes or the oviducts. The uterine tubes conduct the oocyte, that's the ovum, which is discharged monthly from an ovary in the course of the reproductive age, the childbearing years. So the ovum is conducted from the periovarian peritoneal cavity to the uterine cavity. Many thanks to the uterine tube on that side. The uterine tubes also provide the usual site of fertilization. They extend laterally from the uterine horns and open into the peritoneal cavity near the ovaries. The uterine tubes are about 10 cm long. They lie in the mesocervix in the free edges of the broad ligaments. The uterine tubes extend symmetrically, posterolaterally to the lateral pelvic walls, where they arc anterior and superior to the ovaries in the horizontally disposed broad ligaments. When you do ultrasound examination, you will really appreciate that the uterine tubes are actually, in most cases, asymmetrical. They are arranged with one or the other lines superior and then posterior to the uterus. The uterine tubes have 4 parts, from lateral to medial. You have the infundibulum, the funnel-shaped distal end of the uterine tube that opens into the peritoneal cavity through the abdominal ostium. You have finger-like processes. That's the fimbriated end of the infundibulum, what we call the fimbriae, spreading over the medial surface of the ovary. You have one large ovarian fimbriae attached to the superior pole of the ovary. The second part of the uterine tube I must mention is the ampulla. This is the widest and longest part of the uterine tube. The ampulla begins at the medial end of the infundibulum, and fertilization of the oocyte usually occurs in the ampulla. Next is the isthmus. The isthmus is the thick-walled part of the uterine tube which enters the uterine horn. Then, of course, you have the uterine part of the uterine tube. This is the short intramural segment of the uterine tube that passes through the wall of the uterus and opens via the uterine ostium into the uterine cavity. This opening is at the uterine horn. I'm not happy to talk about infections of the female genital tract, because the female genital tract communicates with the peritoneal cavity through the abdominal ostium of the uterine tubes. You could have infections of the vagina, uterus, and tubes, uterine tubes. Such infections can result in peritonitis because of this communication with the peritoneal cavity. Also, when there's inflammation of the uterine tubes, what we call salpingitis, it could result in you could have it coming from infections that occur in the peritoneal cavity. So infections in the peritoneal cavity could result in inflammation of the uterine tubes. A major cause of infertility in women is blockage of the uterine tubes as a result of inflammation, salpingitis. What about patency of the uterine tubes? If you want to appreciate patency of the uterine tubes, you might have to do hysterosalpingography. Patency of the uterine tubes may be determined by this procedure, a radiographic procedure that involves injection of the water-soluble radio-opaque material into the uterus and tubes. Is a contrast substance so that at the end you can visualize the uterine tubes and uterus clearly. The procedure is called hysterosalpingography. Endoscopy. Endoscopy is another procedure where patency of the uterine tubes can be determined, and when you do it, when you see it through the uterus, it's called hysteroscopy. So you examine the interior of the uterine tubes using an endoscopic instrument like what we call hysteroscope, and you introduce the hysteroscope through the vagina and uterus. So endoscopy enables you to determine the patency of the uterine tubes as well. What about ligation of the uterine tubes? Ligation of the uterine tubes is a surgical method of birth control. That's a drastic thing to do. Oocytes discharge from the ovaries that enter the uterine tubes of patients that have done ligation of the uterine tubes. Such oocytes will degenerate and they will get resorbed. Most surgical sterilizations are done. You could do it through the abdominal, by way of abdominal tubal ligation, or you could do laparoscopic tubal ligation. Abdominal tubal ligation is usually preferred, and it's usually performed by means of a short suprapubic incision made at the pubic hairline. Laparoscopic tubal ligation is done with a laparoscope, which is similar to a telescope. The laparoscope has a powerful light. The laparoscope is inserted through a small incision, usually near the umbilicus. Now, I'm also sad to talk about ectopic tubal pregnancy. You have it in some women. There's collection of pus that develops that can develop in the uterine tube, what we call pyosampics. And the uterine tube may be partly occluded in the cause of inflammation and formation of adhesions. So in such cases, the blastocyst may not be able to pass along the uterine tube. So even if you have sperms, sperms could pass because the sperms are tiny and they fertilize. But after fertilization, the blastocyst that is formed cannot pass through the uterine tube to get to the uterus for implantation because of there's an occlusion of the uterine tube. So the blastocyst may implant in the mucosa of the uterine tube, This is what we call ectopic tubal pregnancy. The implantation may occur in any part of the uterine tube, but the commonest part is the ampulla, because the ampulla is the widest. Tubal pregnancy is the most common part of a common type of ectopic gestation. You have it in about 1 in every 250 pregnancies in some part of the world. If it's not diagnosed early, ectopic tubal pregnancy may result in rupture of the uterine tube, and in such a case you could have severe hemorrhage into the abdominopelvic cavity in the first 8 weeks of gestation. If there is a rupture, tubal rupture, you could have associated hemorrhage, and this is life-threatening to the woman, and it also results in death of the embryo. So on the right side of the body, you know the appendix lies close to the ovary and uterine tube. So because of this close relationship, a ruptured tubal pregnancy on the right could result in peritonitis. So at times you could have some people wrongly diagnose it as acute appendicitis. In both cases, the parietal peritoneum is inflamed in the same area. So the pain is referred to the right lower quadrant of the abdomen. So the pain of an acute appendicitis and the pain of a ruptured right tubal pregnancy is referred to the same right lower quadrant. So there could be misdiagnosis. Now a word about remnants of the embryonic ducts. Less often you have mesosampics between the uterine tube and the ovary containing embryonic remnants. We call the epiphorum, which forms from remnants of the mesonephric tubules of the mesonephros. That's the embryonic transitory kidney. Then you could also have persistent duct of the epiphorum, duct of Gartner. This is a remnant of the mesonephric ducts that forms the ductus deferens and ejaculatory duct in the male. It lies between the layers of the broad ligament along each side of the uterus or the ovary. A vesicular appendage is sometimes attached to the infundibulum of the uterine tube. This is the remnant of the cranial end of the mesonephric duct that forms the ductus epididymis. Although all these vestigial structures are mostly of embryological and morphological interest, less often you could have fluid accumulation and the formation of cysts like Gartner duct cysts. That is where the situation becomes problematic. Now I cannot help talking about the ovaries. The ovaries are illustrated right here. The ovaries are almond shaped, and there's also size. Their size is also like that of the almond. They are the gonads, the female gonads. So the ovaries are the female gonads in which the ova develop. The ovaries are endocrine glands that produce reproductive hormones. The ovaries are located near the attachment of the broad ligaments to the lateral pelvic walls. The ovaries are suspended from both the lateral pelvic walls by peritoneal folds. The ovaries are suspended from the superior aspect of the broad ligaments by the meso-ovarium, and they are suspended from the lateral pelvic walls by the suspensory ligaments of the ovaries. What do you have in prepubertal females? In such individuals, the surface of the ovary is covered by a smooth layer of ovarian surface epithelium, which is a single layer of cuboidal cells that give the ovarian surface a dull grayish appearance, which contrasts with the shiny surface of the adjacent peritoneal meso-ovarium, which is continuous with it. After puberty, what happens? The surface of the ovary becomes progressively scarred and distorted because of the repeated rupture of the ovarian follicles and discharge of oocytes that you have in the course of ovulation. The scarring is less in women who have been taking oral contraceptives that inhibit ovulation. The ovarian vessels, blood vessels, lymphatics, and nerves pass to and from the superiorlateral aspect of the ovary within the suspensory ligament of the ovary, which actually constitutes the lateral part of the mesoovarium of the broad ligament. The ovary also attaches to the uterus by ligament of the ovary, which runs within the mesoovarium. This ligament is a remnant of the superior part of the ovarian gubernaculum of the fetus. The ligament of the ovary connects the proximal, that's the uterine end of the ovary, to the lateral angle of the uterus, and you find this just inferior to the entrance of the uterine tube. Note that because the ovary is suspended in the peritoneal cavity and its surface is not covered by peritoneum, the oocyte expelled at ovulation passes into the peritoneal cavity. However, its intraperitoneal life is short because it's usually trapped. That's the oocyte lives within the peritoneal cavity for a very short while because it is usually trapped by the fimbriae of the infundibulum of the uterine tubes, and then the oocyte is carried into the ampulla where it may be fertilized. Now I need to talk about laparoscopic examination of pelvic viscera. Visual examination of pelvic viscera is needed in diagnosis of many conditions that affect pelvic viscera, such as ovarian cysts and tumors, cases of endometriosis, that's when you have functioning endometrial tissue outside the uterus. Then outside the uterus, and in cases of endometriosis, when you want to make a diagnosis, you might need to do visual examination of the pelvic viscera. In cases of ectopic pregnancies also, you might need examination of pelvic viscera. So laparoscopy is very important. It involves inserting a laparoscope into the peritoneal cavity through a small incision. The incision is about 2 cm and the incision is done below the umbilicus. Insufflation of inert gas creates a pneumoperitoneum that provides space to visualize, and the pelvis is elevated so that gravity will pull the intestines into the abdomen. The uterus can be externally manipulated to facilitate visualization. You could also have additional opening spots that are made to introduce other instruments for manipulation to enable therapeutic procedures like ligation of the uterine tubes to be done. Now I must talk about neurovascular structure serving the uterus and uterine tubes. The arterial supply of the ovarian, neurovascular structure serving the ovaries and uterine tubes. Neurovascular structures serving the ovaries and uterine tubes. Arterial supply of the ovaries and uterine tubes is via ovarian arteries that arise from the abdominal aorta and descend along the posterior abdominal wall. At the pelvic brim, these arteries cross over the external iliac arteries and veins and enter the suspensory ligaments. And as they do so, they approach the lateral aspects of the ovaries and uterine tubes. The ascending branches of the uterine arteries are actually branches of the internal iliac arteries, and they course along the lateral aspect of the uterus to approach the medial aspects of the ovaries and uterine tubes. Both the ovarian and ascending uterine arteries terminate by bifurcating into ovarian and tubal arteries, which supply the ovaries and uterine tubes from opposite ends, and there is anastomosis with each other. This gives a collateral circulation from between abdominal and pelvic structures, so both enjoy the collateral circulation. Now, a word about venous and lymphatic drainage of the ovaries and uterine tubes. Veins draining the ovary form what we call the pampiniform plexus of veins in the broad ligament near the ovary and uterine tube. The veins of the plexus usually merge to form the ovarian vein. The ovarian vein leaves the lesser pelvis with the ovarian artery. The right ovarian vein ascends to enter the inferior vena cava. The left ovarian vein drains into the left renal vein. The tubal veins drain into the ovarian veins and uterine venous plexus. The uterine venous plexus is also called the uterovaginal plexus. Now, the lymphatics, you must not forget about the lymphatic vessels. The lymphatic vessels from the ovary drain those from the uterine tubes and fundus and follow the ovarian blood vessels as they ascend and now get to the right and left lumbar lymph nodes or the caval or aortic lymph nodes. Innervation of the ovaries and uterine tubes are derived from the ovarian plexuses descending with the ovarian blood vessels. Innervation also comes from the uterine or pelvic plexus. The ovaries and uterine tubes are intraperitoneal and thus they are superior to the pelvic pain line. There are visceral efferent pain fibers which ascend retrogradely with the descending sympathetic fibers of the ovarian plexus and the lumbar splanchnic nerves. So these go to the cell bodies in the T11 to L1 spinal sensory ganglia. You also have visceral efferent reflex fibers which follow parasympathetic fibers also retrogradely through the uterine or pelvic and inferior hypogastric plexuses. And there are pelvic splanchnic nerves that the visceral efferent also follow, and these visceral efferent fibers eventually go to cell bodies in the S2 to S4 spinal sensory ganglia. You have a table here showing the lymphatic drainage of the pelvic organs, not just the female, the pelvic organs that you find in the female genital organs that are found in the pelvic cavity and also in the perineum. Their lymphatic drainage are all illustrated here. Thank you so much for listening. Don't forget to subscribe to this channel. Goodbye for now.